Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about Lichen Simplex Chronicus or chronic dermatitis. Definition: Lichen Simplex Chronicus, also called Neurodermatitis, is a chronic eczematous eruption of the skin that is the result of scratching. Pruritic precedes the scratching and may be precipitated by frustration, depression, and stress. The scratching then causes the lichenification and further itching, resulting in an itch cycle that perpetuates the process. Prevalence: the estimated prevalence of Lichen Simplex Chronicus or LSC in the general population is about 1 to 3%. This photo is showing a Lichen Simplex Chronicus. We can see lichenified pink plaque on a scrotum, and epidermis is thickened, and in dermis, perivascular inflammation is present. History: some patients with Lichen Simplex Chronicus have a history of emotional or psychiatric conditions. However, for most it is simply a nervous habit. Preceding the eruption, the patient has a pruritic area of skin that is scratched, producing a plaque of chronic dermatitis. Note: itching typically precedes the rash of Lichen Simplex Chronicus. Physical examination: the patient may appear anxious and may talk with pressured speech. There may be little insight into the cause of the eruption. The lichenified plaque always occurs within the reach of scratching fingers. Differential diagnosis: the diagnosis of Lichen Simplex Chronicus is usually obvious in patients who have a localized itching plaque of chronic dermatitis. Chronic contact dermatitis should be considered from a topical medicine used to treat the symptoms. Several more serious psychodermatoses are habitual or neurotic excoriations, factitious dermatitis, and delusions of parasitosis. Habitual or neurotic excoriations are characterized by linear dugout lesions that typically spare the upper mid-back, where scratching fingers cannot reach. This condition appears to be more common in women and can start in teenage years. Factitious dermatitis is a self-inflicted injury of the skin that presents as a bizarre eruption, often ulcerated with linear and geometric outlines. The patient's history is vague and unclear. The diagnosis is made when the clinician has a high index of suspicion in a patient who has apparent secondary gain from perpetuating the condition. Delusions of parasitosis occur in disturbed or anxious, often eccentric individuals. This disorder begins as intractable pruritus with a crawling sensation in the skin. The patients are convinced that they are harboring parasites and usually bring specimens to prove infestation. These bites of material or skin must be examined to rule out the true infestation and to assure the patient of your interest in the problem. More than half of these patients have no visible skin lesions. Those with active lesions have excoriated crusted papules secondary to peaking. Illicit drug addiction should also be ruled out. Here we can see habitual or neurotic excoriations with linear white scars and red dugout excoriations. Laboratory and biopsy. The biopsy in Lichen Simplex Chronicus is non-specific, showing only chronic dermatitis. Therapy: treatment may be difficult, particularly if the patient has poor insight concerning the nature and cause of the eruption. Topical steroids under occlusion, which protect the ear from scratching fingers, and intralesional triamcinolone suspension 10 mg per milliliter are helpful. Antipsychotics and antidepressants have a role in treating underlying emotional difficulties if such conditions are present. The conclusion of therapy for Lichen Simplex Chronicus: initial therapy includes steroids like a topical steroid under occlusion and intralesional steroid like a triamcinolone suspension 10 mg per milliliter, and emotional support. Alternative therapy include antipsychotics and antidepressants. Cause and complications. Lichen Simplex Chronicus is a chronic waxing and waning problem that accompanies the mood change of their patient. Clinical case: a 41-year-old woman presents with a persistent, intensely itchy skin lesion on the nape or her neck that has been present for more than 6 months. She reports frequent scratching, especially at night, which temporarily reveals the itching but worsens the lesion over time. She has a history of anxiety. On examination, there is a well-demarcated, thickened, hyperpigmented plaque with accentuated skin marking and mild excoriations. No vesicles or scaling as seen elsewhere on their body. Which of the following is the most likely diagnosis? A. Psoriasis vulgaris. B. Lichen planus. C. Lichen Simplex Chronicus. D. Atopic dermatitis. And E. Tinea corporis. According to our explanations, the correct answer is C, or Lichen Simplex Chronicus. Explanation: Lichen Simplex Chronicus results from chronic scratching or rubbing leading to lichenification, as we explained. Common sites include nape of the neck, ankles, scalp, vulva, and scrotum. Lesions are thickened plaques with exaggerated skin lines and hyperpigmentation, often associated with psychological stress or anxiety. Differential diagnosis: psoriasis, well-demarcated erythematous plaques with cellular scale, lichen planus, while luscious flat top papules with Wickhamsturia, atopic dermatitis, eczematous lesions with flexural involvement and childhood onset, and tinea corporis presents as an annular lesion with central clearing and scaling edge. Okay, this was a short explanation about Lichen Simplex Chronicus or Neurodermatitis. Thank you for your attention.